What's going on, guys? Welcome back to the channel and back to another video, and today we're going to be discussing the functions of the renal system as well as diagnostic studies used for any abnormalities. Now, this video is the introduction video that is going to welcome in the other 3 videos that are a part of the renal series, and the rest of the videos are about renal or urinary disorders, so be sure to check those out when you are finished with this one. All right, so let's go. So the components within the renal system are the kidneys, which are mainly for excretion of wastes and regulating homeostasis by means of regulating our fluids and electrolytes. Now, the kidneys are retroperitoneal, meaning they are located posteriorly or behind the peritoneum, and the peritoneum is just a membrane that surrounds our abdominal organs. Now, guys, follow the image to the right. When urine formation occurs, blood is filtered at the level of the kidneys, and when this filtration occurs, both water and solutes are passed through capillaries within the kidneys, and the urine then travels through the ureters, which are those white structures within the image. As they travel through the ureters, urine then goes to the bladder. Now, below the bladder is the urethra, and this is a passageway that urine travels through when we void or micturate. Now, the kidneys serve to form urine, which occurs in the nephrons of the kidneys, and also that of excretion, guys. The kidneys forms urine and excretes wastes and fluids. So our kidneys regulate fluids and electrolytes and our acid-base balances as well, that of bicarbonate and acids within the body. Moving along, this is where it gets really cool. Our kidneys secrete various hormones in our body, 2 being EPO and renin. Now, EPO stands for erythropoietin, and this is what is the hormone responsible for the production of erythrocytes. So EPO is going to stimulate our bone marrow to produce our red blood cells. So if there's any renal impairments, EPO will not be released when we need it. Therefore, we will have a decrease in our red blood cells, furthermore classifying the complication as anemia. As for renin, this is another hormone that is released in response to decreased blood pressure, hypotension. So the kidneys regulate our BP as well, guys. Keep that in mind. So the body will recognize that there is a low blood pressure, and renin will pretty much increase our blood pressure. And I'll show you guys exactly how in the next slide. Lastly, another function of the renal system is that it activates vitamin D, and vitamin D is what absorbs calcium within the GI tract, the gastrointestinal tract. Now, if there's any renal impairment, guess what? There will be no absorption of calcium, and that will make one hypocalcemic, low calcium, due to the low calcium absorption. Yeah, I know, you're probably so excited you're about to fall off your chair, but it gets even better. And this is where it gets better. So here is the renin angiotensin aldosterone system, aka the ROS system. And no, this is not what Jamaicans refer to when they say the word ROS, guys. But as mentioned before, when fluid volume is low, renin is the enzyme that will be released to increase our blood pressure. So follow along in the image, guys. The first thing that will trigger the renin release is a decreased blood pressure. So when your blood pressure is low, renin will be released. And once renin is released from the kidneys, the liver also releases something called angiotensinogen, okay, angiotensinogen. Now, once renin runs into angiotensinogen, it will convert into angiotensin 1. So renin and angiotensinogen must meet before the synthesis or creation of angiotensin 1. Just think that renin and angiotensinogen is the parents of angiotensin 1. Now, the lungs is going to release a angiotensin converting enzyme called ACE. And this ACE runs into angiotensin 1, which will make it angiotensin 2. Now, angiotensin 2 is going to stimulate the hypothalamus, which will trigger thirst. And when we consume fluids, our fluid volume will increase, furthermore increasing our blood pressure. The hypothalamus also creates something known as antidiuretic hormone. And antidiuretic hormone, guys, is released by the posterior pituitary gland in response to low blood pressure. Now, antidiuretic hormone serves to reabsorb water and releases it into the vascular system. And once, water is released into the vascular system, this brings up fluid volume, furthermore bringing up blood pressure. Lastly, angiotensin 2 is going to stimulate the adrenal cortex of the kidneys to release aldosterone, which is going to promote the retention of both sodium and water. It's going to hold it back, not allowing it to be excreted. And when we hold back sodium in water, this is another mechanism that's going to bring up our blood pressure. So all of this stimulation that we've just discussed All of them will lead to an increased blood pressure, guys. I know, amazing. Moving on, when we're doing a physical renal assessment, we're going to start with inspection, inspecting the skin and the skin turgor, along with the color and its texture. Also the extremities for edema, as well as the abdomen, okay? Next is auscultation, and we're going to auscultate the renal arteries to see if there's any turbulent flow or sounds that may point to increased fluid volume. This is the brewy sound. We don't want to hear that sound. It indicates a disruption of blood flow, guys, either too much or too little. So we don't want to hear any abnormal sounds upon auscultation. Next is palpitation, and palpitation occurs under the flank area, near the iliac crest, and we're palpating to feel the bladder for distension. If there's a full bladder and urine is not getting out of the body, the bladder will be palpable, and it's not supposed to be palpable. It's only palpable if it's filled up with any urine, and that would lead to oliguria. So we're not excreting any urine, therefore it's backed up, and if that's backed up in the system, so will fluid, and that's what would cause edema, guys. So lastly, we get to percussion, and we're percussing to make sure there is a hollow sound, which will indicate no distension or fullness within the bladder we just discussed. Remember, it should not be full. Also, we want to make sure the patient isn't feeling any tenderness or pain when doing any of the percussion. So here are terms that describe abnormalities when assessing, okay? So there's going to be things such as anuria, which is a decreased urine output. The normal output of urine per day is 800 to 2,000 milliliters per day. Anuria is less than 100 mLs, guys, and that is very low urine output. There's practically no urine output. Next is oliguria, and this is also a decreased urine output, and this is just less than 400 mLs of urine per day, still very low, but anuria is worse than oliguria. Now, polyuria is an increased urine output, more than 2,000 mLs per day, and that's a lot of urine output, meaning a lot of fluid output. Someone could possibly become hypovolemic. Our next term is dysuria, and this is pain upon urination, so think discomfort. Dysuria, discomfort. Enuresis now is the uncontrolled loss of urine at night, so this is bedwetting, guys. It is uncontrolled. Nocturia, on the other hand, is frequent urination at night, and this is the controlled urination, guys, unlike enuresis. So if you drink a lot of fluid throughout the day, especially in the later portion of the day leading to the night, you're going to have nocturic episodes or frequent bathroom visits because of the increased fluid in the body. That's why it's also going to be important to give diuretics early within the day. You don't want to give them too late because patients can suffer from nocturic or enuretic episodes, and we do not want that. Our next term is retention, and this refers to the retainment of fluid within the bladder. Say it's not coming out, this would lead to that distended bladder or palpable bladder. Remember, we do not want that. Moving along, we get to renal colic, and this also refers to pain, but here the pain is spreading or radiating to the perineal or groin area. Lastly, hematuria, and this just means that there is blood within the urine. Now we get to diagnostics and various tests that are done when looking at urine disorders. And there's going to be tests such as blood tests. And when doing blood tests, things such as BUN or bilirubin urinary nitrogen and creatinine are looked at. Now, BUN is for that hydration status, along with the glomerular function. And creatinine is the better lab looked at when talking about kidney function. So keep that in mind. BUN is for hydration, creatinine is for kidney function. Now, BUN's normal value is 8 to 21 milligrams per deciliter, and creatinine's level is 0.6 to 1.2 milligrams per deciliter. So if these labs are low or too high, this will indicate some renal dysfunction. Also, urine tests can be done, and examples include bedside urine dipsticks, which is a non-invasive method used where a stick will be dipped inside of a container, furthermore changing its color based on the pathological findings within the urine. A urinalysis can also be done, and this is a method used to monitor the urine for infection. Also, culture and sensitivity testing can be done, which will identify any bacteria that is present. Also, an IV pyelogram can be done, and we're going to discuss this more in our next slide. As for our imaging studies, sonography serves to see if there is any urinary retention whatsoever, guys. Moving along, something called a cub can be done, and this is a x-ray of the kidneys, ureters, and bladder. Lastly, a CAT scan can be done, and this is the optimal way to go when looking at structures within the kidney or specific body parts in general. Now back to the intravenous urography, that IV pylography, and this serves to examine the size and anatomy of the kidneys. So an iodinized contrast media is injected into veins, and this is going to outline structures within the renal system. So before this examination, we're definitely going to want to check for allergies to either the dye as well as the iodine. Before this examination, we're going to want to make sure the patient consumes nothing by mouth. So providing that NPO status 4 to 6 hours prior to the test or overnight is going to be vital. Now, after this test is completed, we are going to want to increase fluids to get rid of any dye that may be in the body, as well as provide hydration to cells, because remember, they were NPO, therefore they are dehydrated. They're lacking a lot of fluids and they're lacking food, of course. So we're going to want to increase both, and this is going to provide that cellular hydration. A CAT scan, again, is going to be the most optimal diagnostic to look at kidney structure. An MRI now, this test can last up to 90 minutes, and there should be no metals present on the client. Lastly, a cystography and urethrophy can be done, and here a dye is injected in the kidney to see if there is any backflow of urine or infection present. So nursing interventions are things such as getting informed consent from the patient on the tests involved. We're going to make sure that we can do it and they're okay with doing it based on what's going on and the precautions to take. We're going to want that consent for a lot of things from the patient moving on in the plan of care. Also assessing for allergies. If there is any allergies to the dye, we're going to administer steroids and make sure emergency equipment is bedside, such as intubation equipment. Also, we're going to want to check the creatinine levels, making sure that the kidneys are functioning properly. This is going to be very important moving forward in the plan of care. And lastly, making sure or encouraging fluid intake post studies to rehydrate the patient as well as rid the body of any substances that may be present, guys, such as the dye that was injected prior to the test. And this is the end of the presentation, guys. You can follow this video up with Renal Disorders 1, and in that video we're going to discuss incontinence, urinary tract infections, and kidney stones. So see you guys then.